burns.
We also tell people don't break the blisters, another one of those, I don't know if it's a wives' tale.
And skin damage.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
All done together.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Blow hard! Blow, blow, blow! Keep pushing.
Let's try to push your head.
Pull red handle to open bag.
Welcome to On Call. I'm Tammy Watson. We may not think about our skin as a body organ per se, but it really is. It protects us from infections and helps regulate our body temperature. And tonight we're going to talk about damage to the skin. We'll focus in on burns and cover other concerns like frostbite, eczema, pressure ulcers. Here in the studio we have the experts and they are ready for a great discussion about burns and skin damage. Joining us tonight are Dr. Richard Howard, Dr. James McGrann, and the On Call medical editor, Dr. Rick Holm. You can call in with your questions about our topic right now. Our phone number is 1-888-DOCTOR-ON-CALL. Again, that's 1-888-376-6225. Helping answer the phones tonight are volunteers from the South Dakota State University Pre-Professional Science Club and the SDSU Nursing Student Association. Dr. Holm, before you introduce our guests, the proper treatment of burn injuries is one of the things that I hope we talk about tonight. What are some of the other topics that you think we should address?
Well, really what we have is a great plastic surgeon and a great dermatologist here. I mean, we'll go anywhere you want to go on this. And so we said, okay, let's start with burns. I mean, we'll concentrate on burns, but you know what? We'll take any skin, plastic surgery, dermatology question. And those are great arenas for questions.
Okay.
So just let your thoughts go. Give us a call. Would love to have your question and go from there.
All right.
I'm pleased to introduce to you our guests. Now, these guys have been on the show multiple times in the past. We have Dr. Richard Howard from the Sioux Falls Center for Plastic and Reconstructive Surgery, and Dr. James McGrann from the Dakota Dermatology in Sioux Falls. These are seasoned guests, and we're glad to have you here.
Spicy? I'm not
spicy,
sure which
salty might be there. Salty. So, Dick, tell us a little bit about. You're a plastic surgeon.
Correct.
Where are you from? What did you do? Where did you get started? And
Native South Dakotan, USD School of Medicine down in Vermillion. Started out my first 2 years. We left and went to Milwaukee in 1980 for my last years of med school. Swore I would never come back, never want to see another cornfield my entire life. We ended up back in Sioux Falls in 1992 and have been there ever since. We have a truly mom and pop shop. I'm independent by myself. My wife is the business manager, and that's her background is management. So we're really kind of old-fashioned that way.
it's kind of interesting. Sometimes you have to leave home to realize what you've got here. I did the same thing.
Oh, yeah.
I did the same. Jim, tell us a bit about your whole story. You're a dermatologist and a Mohs surgeon.
Mohs surgeon. Similar Dick, South Dakota boy, grew up here, educated primarily here, but had to be trained somewhere else. So I trained at the University of Wisconsin in dermatology and then did a fellowship with Dr. Mohs in Mohs surgery, which is a type of cancer surgery. And so that's how Dick and I got to be friends, because I'd take the parts out and Dick would make them look good. So it was a good thing.
Combination.
You know? After I had made them look pretty tough, he could make them look pretty good again.
That's nice.
So, good team.
So, and have you dealt with a lot of burn patients?
Well, fortunately in this day and age we don't have to because we have Dick Howards to help us. But yes, in my early training, I did some plastic surgery training and did dermatology, and University of Wisconsin did have a big burn center, so we were involved in some of that, yeah.
Great. Well, burn might be a real good thing to start with, but we'll take anything, and we'll talk more about it right after this.
Thermal burns occur when hot metals, scalding liquids, steam, or flames come in contact with your skin.
Major burns can cause devastating and life-altering injuries, and it seems that we become especially aware of this when the trauma affects children. With this in mind, you may want to listen closely to our next story. Shriners International and Shriners Hospitals for Children work together to provide state-of-the-art care for children with burn injuries. This care is offered regardless of ability to pay. It's based solely on a child's medical needs. On Call went to meet with some Shriners at the El Rayed Shrine Temple in Sioux Falls to learn more. This van runs on 4 wheels and a lot of hope. It's the El Rayed Hospital transport van that Sioux Falls Shriners use to ferry children and their families to medical care. Shriner Dennis Verhey explains.
We have transportation vans and a group called the Roadrunners that run our patients back and forth between our hospitals.
There are over 20 Shriners Hospitals for Children, and they treat more than burns. Care for children's spinal cord injuries, cleft lip and palate defects, and orthopedic problems are also specialty areas for Shriners Hospitals. Ike McDonald, one of the Roadrunners who drives the Shrine Hospital transport van, says this service is well used.
Somewhere around 120 trips a year, and that has grown over the years tremendously.
And while these vans see good use, the Shriners sometimes arrange other transportation for burn patients.
Our burns patients in particular, because that is very critical and time sensitive, we usually arrange air transportation to our facility in Cincinnati.
A statue of a Shriner helping a child stands outside the El Rayed Shrine in downtown Sioux Falls. It's a symbol of the organization's commitment to service, and according to Shrine leader Pat Colbert, that commitment includes training for healthcare professionals.
Our hospital system is set up for children of even before birth. We've gotten involved with our care of different areas, and we're an excellent research and training facility also. We train thousands of physicians and nurses in different various areas of healthcare. So we get involved in a lot of aspects of healthcare that we're very proud of.
Shrine-supported medical training extends beyond hospital walls. South Dakota Shriners have also begun to sponsor specialized training seminars for local healthcare providers. Roger Risty is the El Rayed Shrine Hospital Seminar Chairman.
And because of our mission, our goal of the children's hospitals, in particular in Cincinnati with the burn hospital, we brought in a nurse, a lady by the name of Jean Mers, who is an expert at doing these types of seminars. And our goal was to teach first responders, the nursing students, the med students, active nurses, EMTs, how to treat a burn when they come across one, whether it's in a car accident, at home, the initial treatment of burns. And we found that was something that just wasn't being taught in the medical schools or the nursing schools in this area.
An annual golf tournament is just one of the fundraising activities held by the El Rayed Shriners to help support Shriners Hospitals. But if you happen to go to a Shrine Hospital, don't expect to see the doctors wearing the classic Shriner fez.
There's two sides of the shrine. There's a fraternal side that you see in the circuses and the streets and the parades and the events that we sponsor down here. And there's a hospital side.
And if you'd like to learn more about the hospital side of Shriners, you can contact the El Rayed Shrine in Sioux Falls, South Dakota. Their web address is www.elriad.org. Again, that's www.elriad.org. And their phone number is 605-336-1117. Again, that phone number is 605-336-1117. Doctors, the Shriners Hospitals for Children offers specialized care for burns. So what is the special care or special kinds of treatment that burn patients require?
Well, Dick, you trained in a Shriner.
Yes.
Tell us the answer to that question.
Well, part of my training was in Galveston, Texas, University of Texas Medical Branch, and they had one of 3 Shrine burn centers for children there. It was a 30-bed hospital. There were 15 beds for acute burns, so these were, you would see kids with house fires and motor vehicle accidents where we're talking massive 70, 80, 90% burn injuries. And then that was the acute side. The reconstructive side, which was the plastic surgery portion, we would work with these kids and manage them, and they would start from the time they were healed. You take a kid whose child is a year, 2 years old, toddler, they're going to be followed till adulthood. Every year, 6 months or something, have some type of reconstructive surgery done during that time frame.
So it used to be that if you had more than 30%, they struggled to live. Right. And now you're getting out to 80 or 90%.
Correct.
And how can they do that? I mean, basically, if you take a sore, an ulcer, you cannot heal that. The body won't heal that ulcer except from the side. You've got to have skin cells to grow new skin cells, and it gradually closes in from the side. When you have a massive burn, you have to grow it in from the side, unless you...
So if it's burned all around, how does that
How do you do that?
Well, you have to buy time. So if you have a massive burn on, say, these kids, we use a lot of cadaver skin. So it was
cadaver meaning a dead body
dead
skin.
Body. It was a temporary dressing, but it reestablished that barrier and would let you be able to take their own skin, harvest the skin and graft it, then go back and reharvest when that healed, do it again, or also pull some of their own skin and put that into a tissue culture so that you would actually make skin, sheets of skin that you could grow in a laboratory, and then take that and put that on the patient.
I mean, I've heard that. I mean, I remember when it came out. They're doing that now. That's gone from the lab to real in vitro to in vivo already, and they're doing it. And the question is, have you been doing that? Is that at special centers, or
they do it at special centers? So that's the type of thing they're going to do at a major burn center, which we don't have here.
I remember taking a big. I was involved in learning surgery in Watertown when I was a med student. So they'd take a big piece of skin, and then they'd run it through a machine that would basically make it into a mesh, and then you could take this tiny little piece of skin and you could spread it out so you would fill a big space here, and you had this mesh where you had little pieces of skin that could grow into the open wound. Are they still doing that?
Oh, yes. Yep.
Yeah.
Your own skin is really expensive. I mean, you don't have that much. Besides that, donor sites are not very comfortable.
Yeah, it hurts.
It hurts a lot for a donor site. So and when you have a large burn, you've got a big open wound. That's a stress on the body. Now you harvest skin.
And you've got two sweats.
Now you have two. You've doubled the size of the injury to the patient.
Yeah. So, but why couldn't the cadaver skin make it? Why does it have to? You're saying it's a temporary deal. Why doesn't it take? Why doesn't the cadaver skin work?
You have to take it off because your body will allow that to be on there for a while because burn patients are immunologically challenged. They don't reject it right away. But it is a foreign, it's an organ, and it's a foreign body, and your body will recognize that when the immune system recovers
and rejects it. Well, what about chemotherapy or the anti-rejection drugs that they're using for kidney transplants and stuff like that?
Well, because of you've lost the integrity of your preventing bacteria, so you can't compromise the immune system any further than it is, or you'll just get invasive bacteria and die.
Yeah. Jim, you have anything to add to that?
Well, one of the issues when you look at this stuff is you were talking about why do people survive now before? Well, in addition to the skin component, which is critical, there's the real issue of the general damage to the body. And so what really is making a difference now is we recognize that when you get these burns, there's damage to internal organs. There's a huge amount of myoglobin in the fluids. There are
break down
muscle proteins that are going in, and all this damage is going into the kidneys and into the liver and into the heart. And so a big part of this is the intensivist. And so this is why we don't have this ability to do these things in Watertown or Brookings, and we used to do some of these things in Sioux Falls. But the real issue is, if you're going to do this, you have to be expert. So we now have internists that are expert intensivists at the fluid resuscitation and the volumes and the electrolytes and things like this. And Dick was talking about why doesn't the skin work? Well, the artificial skin initially is providing the barrier, but the real issue is unless you have the matrix for that skin to regenerate, they can't make it. So that's where the plastic would be. Well, you have to have a blood supply. You have to have something that's going to allow that skin to heal. So when you put dead skin on dead tissue, you're creating a barrier, and that's going to allow that person to maintain fluids so that they literally don't weep to death, because the acute injury in this thing is usually the fact they're losing heat, they're losing fluid, their electrolytes go out of control. A lot of them die of high volume output. Their heart can't keep up with it. So part of the issue is why we have to have burn units is there's an extreme level of expertise that is the acute. What do you do with these people acutely? You have to protect the kidneys, you have to protect the heart, you have to protect the liver, and that's a specialty all on its own, away from dermatology, away from plastic surgery. So there's a whole other group of intensivists that deal with this, and that's what Dick and I don't do.
It speaks to the Masons and the Shriners and how much we appreciate the fact that there has been this need in this country, or every country really, that has been provided for by that group. And so hats off to the...
Fez is off, right?
Fez is off.
Not only the care that's delivered, but the amount of research that comes out, at least at the Shriners in Galveston, the amount of research that came out of there was phenomenal. 100 and 150 major papers published a year that came out of there.
Wow.
I've forgotten, it's Cincinnati, Galveston, and I've forgotten the...
Boston.
Boston, okay. I'm going to dive into, we have a question, a burn question from Sioux Falls. I used to weld a lot, and I have many burns and marks. If they're healed up, should I have any concern about future problems with them?
Well, it's an injury and it's healed. So realistically, the answer is no. I mean...
But let's say you got pock marks all over your face from welding marks, and they're not pretty. Can you go in there and dermabrase them and make them look better?
We can both approach it from both directions, and we can both help them. Yeah, I can take a laser and smooth out some areas. He can reconstruct areas. They're help both directions.
Oh, excellent.
Depends on what you're doing. If you got a deep pock mark, sometimes you have to excise that and close it. If they're just rough areas, laser resurfacing, dermabrasion, all options.
All right, this is shifting gears a little bit, and this is a question that was emailed in actually a little while back. The viewer lives in Sioux City, watches the show with his girlfriend. They were wanting to know about eczema. Girlfriend has been suffering from eczema for the last year. It's on her arms, wrists, and face. She doesn't like to use the steroid cream. She prefers to use natural things like mineral oil and such. And could you talk about this? What are some of the reasons why somebody might not enjoy the steroid creams, and are there useful
define
alternatives?
eczema first, Jim.
Yeah.
Well, eczema is injured skin. So when you look at the skin, it's either going to dry out or you're going to put a chemical on, you're going to injure it, and two things happen. The skin is injured, it's inflamed, and that's what cortisone helps you with. But the second thing is you lose the barrier function. So when you look at why do doctors use cortisones, because the cortisone will heal the injury. Now, if you give the body long enough, it will heal the injury, but there's a second element, and that is barrier function. And so just using a cream or a lotion may give you some temporary relief, but unless you actually repair the barrier, you can't get it to heal. So, sometimes there are some very simple over-the-counter products that will work. The Vaseline is a great product. Utterbalm is a good product. If you're patient enough, long enough, you can get the job done. But the real issue is so many people, when they have eczema, they continue to injure the skin because they're scratching, they're irritating. And that's why we use the steroid, because when you take away the inflammation and you take away the irritation, now they're comfortable and they're not continually injuring. So yeah, it's theoretically possible to heal the skin without a steroid, but you're going to have to repair the barrier and you're going to have to not continue to injure it.
So what's the cause of eczema in the first place?
Well, the huge majority of eczema in South Dakota is plain old dry skin. We've got hot, dry air coming out of the furnace. We don't like to smell, so we bathe on a regular basis. And when you wash with soap, you saponify and you remove the oils.
That's a good word.
So
What is saponify?
Saponify is you put a soap on the skin, it strips the oils away. So when you clean with soap, you're removing the oil from the skin.
Your natural, good protector oil.
Okay. So we don't want to smell, so we bathe routinely. So what happens is you're taking the oil away, you got dry skin around you, you lose the protection, and that skin starts to get injured. If you're turning into an old geezer like me, you don't repair that oil as quickly. And so one of the issues is the older you get, the slower you heal. So my advice for these people is look at the basics. If you've got a humidifier at home, use it. Get the filters in there and get your air up to 35%. If you need to bathe routinely, and you should, if you're a young kid, you probably should, because people will talk about you if you don't. If you're a little older, you can go a few days because you don't make as much oil and you can get by. But when you do bathe, use a gentle cleanser. And I don't usually drop too many names, but Dove is great because it's inexpensive. It's not soap. It's a cleanser. You can gently wash with it and not injure the skin too much. But even in that situation, if you're living in the northern plains, you have an obligation when the furnace goes on in the fall to the furnace goes on off in the spring, you've got to put some lotion on that skin and create a physical barrier because you're losing that barrier function.
Better right after the shower, put this cream
Get on, dry off, put the moisture on. If you put a bath oil in the bathtub, now you're putting yourself at risk for a fall.
What about the idea of hot water being a big cause of the dry
Well,
skin?
heat makes the soaps work more efficiently. So if you take a hot bath and you use soap, you're stripping the oil more effectively. Think about when you wash the dishes. If you put dishwater in cold water, how well does it clean? Heat that water, put the soap in there, and boy, it really strips the oils away. That's exactly what you're doing when you're bathing. If you use hot water and strong soap, you're creating a more efficient way to strip that oil away.
You can see this dry skin on people's backs, and it's because they just standing there in the hot. I mean, I'm one of them. Oh, it's so cold out. Oh, that feels so good. But dry skin. So before you, turn it down to a little not so hot, and then when you're done, have your partner smear it with cream.
I was going to ask, gloves in the winter, gloves to do dishes, rubber gloves. Does that depend if you're dealing with eczema on your hands? Is that?
Well, gloves are a physical barrier, but if you leave them on too long, you're going to sweat underneath, and then now you've created a secondary injury. So what I tell people is, if you're going to buy gloves, get the cotton-lined ones, Playtex Bluette. They have a cotton liner in there. They help you keep the perspiration away. When you're done with that, take those gloves, dry them out, and then rinse your hands under cool water and put a light moisturizer on. That's the way you got to do it to stay safe.
Great answers for eczema. Dick, you have anything to add?
He is the eczema expert. I sent all my eczema right
eczema
there.
master.
Yeah. HRS.
All right, we've got a question from LeBolt. Gentleman, what causes a red rash on the outside of the bottom of his right foot? Has had bifemoral bypass ×2, doesn't know if circulation is a factor. So you want to explain what bifemoral bypass is?
Well, he's had artery bypass. In other words, he's had blockage of his arteries to his legs. And he's got a rash on the outside of his foot. It could be fungus, it could be eczema, it could be a variety of different things. And so I would go to the dermatologist or your primary care doctor and have them diagnose it and treat it. Jim, you'd add?
Well, your answer is correct, Rick. That's exactly what you'd look for. If there is a vascular problem, usually vascular problems can be identified fairly simply. If it's an issue of a lack of supply, you can press that area with your thumb, take your thumb away, and see how quickly it takes for that to refill with blood. If it doesn't refill pretty quickly, you're not getting a good blood supply. That's probably your best answer.
And generally, though, the vascular problems don't present with a rash on the outside.
Usually aren't red on the outside.
Yeah, I think it's probably not it. Dick?
I agree.
Okay.
100%.
Before we get to this next phone call question, frostbite and frost nip. That's something that I think we.
Here's our frostbite and frost nip expert. We've been seeing a little bit of that.
What's the difference?
It's like first and second degree burns. A frost nip is a cold injury where you actually are going to freeze. You've got cold damage to the tissues, but it doesn't blister. and then you get into, and it recovers fairly rapidly. You get a full frostbite. Now you've got such a severe injury to the tissue, to the skin, that as it reperfuses, because that's what happens with frostbite and frost nip, is that you actually slow down, and you stop the blood flow, and you've got cold injury in a frostbite. Now you've got ice crystals that form in the tissues, and when it reperfuses, you get big blisters.
Okay.
Can you get a through and through burn experience, a 3rd degree through and through ulcer as a result of frostbite?
Oh yes, you can. You've got 2nd, 3rd, 4th degree frostbite, you get something like that, basically the whole extremity is now frozen solid and doesn't recover.
So there is no question about it. It's very much like a burn, isn't it? It's
very similar. We just classify them as thermal injuries. Frostbite injuries have the added thing you were commenting, or heard you talking earlier about pain after the burn.
Yeah.
Frostbite is even worse. You get a neurologic injury that can persist for months afterwards.
So the nerves get damaged, and it's just gonna.
It can continue for a long time. That sometimes is the worst part of it.
So how long does out in the cold? How do we know we've got it? How do sometimes you lose feeling, therefore you may not be aware. I mean, what's some words of wisdom about frostbite?
Well, you got to keep things covered. I mean, that's a frostbite. Ears, hands, at least keep them, particularly in the Great Plains here, because you get out in the cold and say, well, it's not so bad in town or something like that. Now you get out there and your car gets stuck and you go walking somewhere and I don't have something for my ears, or I forgot my gloves, and just the exposure to the cold. If you keep things covered, stay out of the wind, that's the best thing. When you start, things will ache before they freeze, and your hands start aching, your feet start aching, and it's feeling that you've never experienced before. You're getting close to getting frostbite. I got this winter while I was hunting, but it's like, no, it's time to go in. It's too cold. 10 below zero is not a good time to be outside sitting there.
That pheasant or deer is not worth it.
No.
No, it isn't.
Now, we've got to go to tape real shortly, but Dr. McGrann, you mentioned before the show something called the hunter's response. Now, that kind of...
Dick and I were talking about that, and dermatologists have to have a name for everything. So what happens is that the body tries to protect things. So when you get an area that's injured and you start to freeze it, the body's going to try and heat that area. So the initial response is that your hands or feet get cold, the body sends extra blood to that area to heat it. That's called the Hunter's reaction. But if it's so cold that the body can't maintain the core and still do that, it will selectively choose not to put that blood in the hands or feet, bring it back to the core and protect the core, survive the core. You can lose your hands, you can lose your feet and survive, but you can't lose your heart. So the body will selectively shut down blood supplies to the hands and feet. That's called a hunter phenomenon.
Okay. Well, we're going to shift gears real quick and head to the videotape to learn more about the types of burns that healthcare providers see on a regular basis. I spoke with a physician's assistant from Brookings, South Dakota. He shared with me some stories of caution regarding the causes of burns. Rod King is a physician's assistant at the Avera Brookings Medical Clinic. He has seen the usual sunburns and motorcycle exhaust pipe burns in patients, but certain burn injuries stand out in his memory.
I remember I had a patient, an elderly patient one time that came in with a 3rd-degree burn on her back, and she had slept, spent all night long on a heating pad. And, heating pads, particularly if they're used with moisture, can definitely create enough heat to cause some serious injury. So I always caution people, ever since my experience with that, is, don't use a heating pad for any extended period of time.
Another unlucky patient had combined injuries due to a fall and a burn.
And another thing I caution people about, I had an elderly patient one time also that fell into a bathtub and hit the hot water as he was falling, turned the hot water on, unfortunately passed out as he fell, and ended up with 3rd-degree burns all over his back from the hot water.
King's comments are a good safety reminder. The U.S. Department of Energy recommends setting the thermostat on a home water heater at 120 degrees Fahrenheit in order to avoid scalding. King recommends a common sense approach to treating minor burns at home. Cool it down,
You can submerge the burn in cool water and keep a sharp eye out for infection.
Other measures that certainly can be done if there are blisters that are formed at the time of the injury. We also tell people don't break the blisters. Another one of those, I don't know if it's a wives' tale, but things that people hear, they want to pop. They always want to pop blisters, stick a needle in a blister, which we discourage people from doing. If blisters are present and are already broken from the injury, we generally recommend getting rid of that dead tissue, either removing it with a tweezer or something like that, something clean, and trying to get rid of that dead tissue or cutting it off somehow. But to leave the intact blisters alone.
If you've had a skin infection, blisters, burns, or other trauma to your skin, you may have a loss of pigmentation in the affected area.
Thank you for joining us tonight. We're talking about burns and skin damage. And here in the studio, ready to answer your questions, are Dr. Richard Howard, Dr. James McGrann, and on-call medical editor, Dr. Rick Holm. And we're going back to the questions right now. A question from Yankton, and this is talking about skin. What are the mechanisms to help prevent or remove skin tags? What are skin tags?
Yeah, acrocordon. What are acrocordon, Dick?
It's a little tiny polyp of skin. Usually you'll see them grow primarily in the armpit and around the neck. And theories are that there's a little constant irritation, say from clothing or a necklace or in the armpit or something like that, and you'll develop these little
tags.
They're just little tags. It's exactly what they are, little tiny skin tags, and they're little tiny skin polyps.
Mm-hmm.
And grandma would nip them off with a fingernail clipper.
Which is a decent way to do it, don't you think?
It'll work.
It works.
It depends.
They bleed a little bit.
They bleed a little bit, and
sometimes get infected.
It's a little, it hurts, but
so
it'll work.
Let the doctor use the fingernail clippers, is what you're saying.
It's a lot cheaper with the fingernail clippers than the doctor.
But it's not like a pre-cancer risk or anything?
No, they're not tainted, but you have to remember they are cosmetic, so your insurance company will not cover it. So if you meet a gentleman like Dick or myself and you ask us to take them off, we'll do that, but it's highly likely that that will be not covered by your insurance.
Okay. So
Unless you go to a guy like me and I go, well, that's part of the runny nose and the hacky cough and the heart failure and the and while you're there, you just kind of clip them pretty quickly. I know that there's a better way to do it, but I just do a bunch real fast.
Okay.
You have any problem with the way I did it? A little silver nitrate. I used to do a lot of lidocaine, and sometimes I just grit your teeth a little bit. Will you? Clip, 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 clip. Ow! Ooh, ooh, ooh.
You do that in South Dakota.
South Dakota, they do all right with that.
All right, a question from Sioux Falls, just moving on. A lady age 45 has actinic keratosis, help me with that. And so does her dad, so is there a likelihood that they'll develop skin cancer?
Actinic keratosis. Dr. McGrann, you were lecturing me on this about 20 years ago at the CAC meeting.
Yeah, well, essentially, it's a precancer. Actinic keratosis is sun damage. If you get enough sun, you damage the skin, and those cells start to turn irregular. In the huge majority of time, if they're left to their own devices, they will turn into cancer because literally actinic keratosis is cancer in situ. So it's an argument.
In situ meaning
it's cancer in the skin, but it hasn't spread below. And so we can come up with different names. Some surgeon or some pathologists say it's carcinoma in situ. It's not actinic keratosis, but they literally are precancerous lesions, and they usually should be attended to.
And so you attend to them with cryotherapy?
Cryotherapy is the least expensive. If you can do that, it works well. In some cases, we'll use topical agents like Effudex or Aldera. In some cases, they're very severe, and I've sent cases to people like Dick to have them dermabrade or remove them because sometimes they're so extensive they require additional therapy.
I do a ton of cryotherapy in my office.
Which is not holding an ice cube next to it.
It is close to it. It's using liquid nitrogen. Jim, explain cryotherapy.
Well, essentially, you're looking for a quick way to destroy this injured skin, and so liquid nitrogen is 300 below zero. So you're getting bite in the doctor's office. So you're paying this doctor to create frostbite, but it's a localized control frostbite where you are destroying that skin by freezing it. And it then scabs up, forms a blister, falls off, and when the skin heals, nice normal skin replaces it. So the gift is it's inexpensive. You can get a lot done for not too much money.
Okay. I wanted to ask you, gentlemen, about skin damage due to radiation treatment. You know, a person may be receiving radiation for
breast cancer.
Breast cancer.
Let's take a breast cancer or radiation burn.
Yeah. So, how can you help that patient?
Yeah, Dick.
I rarely ever see that now. You will see the method of delivering the radiation for specifically breast cancer, because I do a lot of reconstruction for breast cancer patients. You'll see the burn. We'll see a redness. They may flake the skin off. They may even get blisters. But generally, you keep a moisturizer around those areas. Those people will heal those areas in quite well. Occasionally, in days gone by, I've seen where additional radiation was required, and you literally the skin is literally destroyed. And now, when I get to them, I'm seeing them where you've got to. There's nothing to do to heal it. It's burned, it's dead, it's gone, and it won't heal in because it's been so damaged. So that requires surgery to bring tissue from somewhere else with its own blood supply as a major flap to bring it in and heal the wound.
I want you to explain some science or chemistry, biology about burns and how they damage. Is it just got to be like the heat or the length of time that you're exposed to it, or there's chemical burns, there's radiation burns. How is this all damaging the skin?
I'd start with saying, okay, skin has layers, and it starts with a dead layer of skin. I mean, just basically as squamous cells, the normal squames kind of move upward. They lose their blood supply, they're dead, and they're the outer layer. Okay, so you've got dead cells, and then you've got live cells that are making these pancakes of layer. And then below that, you've got different layers of skin until below the skin, you have the supportive tissue, the blood vessels and the nerves, and you've got the fatty tissue, and then below that, you've got the muscle. Now take it from there. What about a burn? What happens depends upon where the burn, how deep the burn goes. Take it.
Here's a classic one. Talk about hot water. Set your hot water thermostat at 120 degrees. You put somebody in hot water at 120 degrees, put your arm in there, you've got about 10 minutes before you've got a major burn. You put that water at 150 degrees, you got 1 second. And now you've got a major second-degree burn. You put that in steaming 150-degree water, major burn. So it is length and temperature. So a low temperature will burn over length of time, and a high temperature will burn very rapidly.
You see a lot of this with people who put on heating pads. And even new, good heating pads, if they're left too long, they will cause a burn.
And so I'm going to be lying there and not watching TV and not realize that I'm burning myself?
Yeah.
Do
you have any recommendations about heating pads, Jim?
Well, heating pads are something that can really give you some good relief, but again, common sense comes in. If it hurts and it stings, think about it. What I often tell my little old ladies is, you can only use it for a certain period of time, but if you're not sure about them, put a little blanket between you. Reduce that, because it's like Dick's saying that it's the quantity, it's the extent, and if you can kind of buffer that a little bit, you can reduce it. And I'm not a big fan of heating pads. I kind of like to use, there's some of these inexpensive things where you get this, you throw it in the microwave and heat it up a little bit, and if it's too hot to start with, you're not going to use it. So you let it cool down, but it's going to dissipate the heat and you're not going to get quite as much injury. Whereas the heating pad, it's an ongoing chronic process, and if you're not paying attention, you'll injure yourself.
I can tell you, it was within the last 5 years, I had an area that I was putting the heating pad on, and I thought, well, it got hot, and then it was burning. I mean, I woke up, I shouldn't have, gone to sleep with the heating pad on. So I have, from that point on, said to people, okay, moist heat's good. Get a hand towel, wring it, put a garbage bag on top of that, then your heating pad, and you've got, as you say, a couple layers to protect you, and then be really careful. And if they're a person who's borderline in mental function, you have somebody else responsible.
Okay.
Dick, any comment?
Or changes in sensation. Diabetics. People have chronic back problems. They tend to have nerve injury, and they
don't know that they're
they
burning.
don't know they're burning. Those people many times may be on chronic pain medication, and they may not know. I mean, they can't differentiate the pain of their back with this pain from the burn.
It's
all
happening
pain.
right now with the eating pad.
And they don't even know it. So the people that have some type of impairment of sensation, you combine, you fall asleep. Let's say you had a few too many drinks or something like that, and you put the heating pad on and you fall asleep, and you're compromised because of that.
Yeah.
Well, those are all things that
Bad things can happen.
Bad things can
You have to
happen.
be very careful
Okay.
with heating pads.
Well, off of these comments, Dr. McGrann, you mentioned common sense. So do you have any stories about burns that you've treated, not to tell tales, but things that drove home to you kind of the necessity of being careful?
I'll give a quick story. A guy is being chased by the police. He had too much to drink. I was in the emergency room when they caught him, barely. I mean, he was hiding behind a tree. And he's running around, and it's 10 below zero, and it's blowing. It's a blizzard. And he's hiding from them because it's going to be a DWI. And he's really smashed. And so they found him, barely, dragged him in, and his hands were frozen. And the result was huge injury to his hands. I mean, it was major burns and lost tips of his fingers, and tough case. And he was in pain for a long time after that.
Okay.
Any other good cases?
Well, the ones I see that are kind of interesting are the stupid things people will do once they're injured. And I mean really stupid, because sometimes they make the injury worse with the things they do with it. So if the skin is injured and you say, well, it's injured, so what should I do? Should I rub it real hard and create more injury?
Mm-hmm.
And then I see that. Or should I take something that's really toxic and put it on there? So they'll see, well, I froze my hand, so now I'm going to put it in hot water. Well, now you've injured a second time. Or they'll take something that's obviously an irritating solution and put it on there. So a little common sense is a great thing to have, and sometimes you just have to slow down and think. And Dick and I talked about this, and Dick, you could tell about the what do you do with a grease fire, and I think that's a great comment.
It's easy. I've seen several of these where they're going to deep fat fry fish, or they're going to pop popcorn. So they put a pan on the stove, they put the oil in, they turn it on high, they get distracted, they answer the phone, something happens, they, oh my gosh, and they come back in the kitchen, and now they touch the pan, and suddenly you've got 6 feet of flames coming out of the pan. Well, that'll get your attention.
Yeah.
And you tend to freak out. So in this, the ones I'm thinking about, the ones I ended up seeing, because they grab the pan,
Pan's too hot, and they burn their hand like crazy.
or they're headed to the door, they're going to take it outside, and they trip. And then they drop the thing, and you can freak out, but the thing to do is just get the lid and put the lid on there, or a plate, or the baking soda is usually on the shelf, so you're not going to get it. That's supposed to work really well, but you can slide a plate, just slide it over the edge of the pan, it'll stop.
But do not panic and be slow.
Do not
in
panic
your
and
movement.
be slow.
That's right. And you should have a fire extinguisher in
always a
your
great
kitchen
idea.
nearby. That's an important issue.
Toddlers will go up, and if you've got a glass oven door, watch out for the toddlers, because they like to go up and look in the oven door and slap their hands on the oven door.
And then they're burned, they're caught.
Yeah, and it takes them, they can't react fast enough. Toddlers' reaction times are very slow, and by the time they move, they've got blisters.
That reminds me of the kitchen tip where you put the pot handles to the side as opposed to front,
yes.
where you can bump them easy. And anyway,
But we can all remember, and we can say that it's stupid, and I was one. I mean, we've all done these things.
Yes.
And so we have to be careful.
okay, back to the questions. A friend beat melanoma several years ago, but recently found out she has another precancerous spot. Will she get melanoma again?
Ooh. Jim.
Well, you know, melanoma is a tumor of pigment cells, and if you get a precancer, it's generally because of sun damage. So precancers or actinic keratosis, they are not precursors to melanoma. Melanoma is usually a mole turning irregular or something like that. So one's an apple, the other's an orange. But precancerous actinic keratosis don't become melanomas. So there's no, you know, the risk factor is if you have a lot of sun damage, a lot of sunburn, you have a big risk for melanoma. It's not related to the actinic keratosis.
What about dysplastic nevi or something like that?
Well, Dick's talking about certain families that have a tendency to get irregular moles, and there is some genetic factor with that. And if your mother or father had melanoma and grandma's got a lot of fuzzy moles, then that's a person that should be getting into a skincare expert and have somebody check them, look at those moles. And Dick and I take these types of moles off on an everyday basis because if you get these irregular moles and remove them in a timely fashion, you can prevent that cancer.
All right. Another question kind of on the broad topic, a caller from Huron. Previously you talked about burning off precancerous cells with liquid nitrogen. What exactly did the skin look like before the treatment? What was alarming that makes it...
Let me explain that actinic keratoses are different than basal cell cancers, which are shiny bordered with central ulcers. Actinic keratoses are actually more palpable than they are visible. You can put your finger across them and it's scaly. It's scratchy, scaly sores that don't get better.
So it might be the same general flesh tone, but I'm going to feel it?
Yeah, you're going to feel it. And you can see them sometimes.
They're usually pink, you know.
Yeah, but you can feel them almost more than you can.
If they're pink and they're scaly, it's a precancer. You know, that's my simple rule.
Pink and scaly. Simple. Straightforward. There you go.
Stick with it simple.
Yeah.
Okay. A question from Rapid City. I have a chronic skin disorder which causes fluid buildup in my legs. I'm already walking, elevating the leg, and not drinking. Is there anything else I can do? They don't name the disease.
Support hose and diuretics and walking, not standing, not sitting, laying with feet elevated. Chronic venous stasis.
That's the answer.
Yeah.
Yeah, well, it could be lymphedema, chronic lymphedema. There are lymphedema. Now, if it's a lymphedema, that's different than chronic venous stasis, so you need to have the right diagnosis. You're going to treat them differently. Lymphedema, compression stockings, they have pumps that are like imagine a big blood pressure cuff that you encase your entire, say, leg in. It's hooked up to a pump. This will work for many folks, not everybody. Venous stasis ulcers are treated with compression wraps. So there are treatments, but there's not a cure for these. There'll be treatments that you have to do to get things under control and keep them under control.
Okay. I'm going to be mean. We're running out of time, and here's a question, though, I want you to touch on real quick. A gentleman age 59 has muscular dystrophy and type 2 diabetes, has skin ulcers on the top of foot, and they're taking a long time to heal. What, you know, in...
And Dick's the
short,
foot ulcer.
Short answer here.
But the short answer is raise the leg, get the edema out, and careful.
See your doctor. Because if this thing gets out of hand, he's going to lose his leg.
Yeah.
Okay, take it serious.
Yeah, take it serious.
All right, seriously, we're just about out of time, but we have 45 seconds for you to impart some wisdom.
Give us some good wisdom here, Dick.
Situational awareness. There's so many things that I've seen with burns that, you know, the pan fires, campfires, the glass door on the oven, you know, things like that. These are things they're accidents waiting to happen in the home. Hot water heaters, I've seen some tremendous, terrible burns. People almost die from a scald. Just be aware of the fact that around the home these things can happen. You got little toddlers around, they change, they move.
Turn the temperature down.
Turn the temperature down.
All right.
Watch out. Keep the kids out of the way when you're cooking.
Yeah.
All right. Dr. McGrann, you want to...
Well, we're in South Dakota. It's winter. You can be old or you can be bold. So if you're going to be smart in this country, you know, prepare to travel, wear a good coat, you know, be prepared for if that car isn't ready to go, you might have to stay there. So, you know, appropriate mittens, a good pair of gloves, a stocking cap, the right things. But if it's not right, don't go.
Okay. Dr. Holm.
And stay in your car. Don't venture out to try to save the day. Thank you, guys. Great, wonderful
Thanks.
Thank you.
Thanks so much. Stay tuned. We'll be right back after this break with the homespun perspective and then what's new in medical science.
Looking for reliable healthcare information online? You can start with the resources link at the On-Call website. From there, you can access a variety of accurate and dependable information sources, including the South Dakota State Department of Health and Medline Plus.
She was removing the pan of hot grease from the stove when she spilled the stuff all over her right hand. One area of the skin was just red, like sunburn, which is defined as a first-degree burn. Another spot blistered, making that burn second degree. But in the center, there was a third-degree burn, where the grease had injured both the inner and outer layers of skin, so severely it caused eventually a small open ulcer. Fortunately, there was no fourth-degree burn, which is when the muscle and the connective tissue below the skin is also injured. Well, she ran cold water on it for 10 minutes and then came in to see me in the clinic. I removed the dead skin gently where blisters had broken, applied antibiotic ointment with silver and sulfa, and a cotton gauze dressing to the injured skin, and then prescribed pain medicine. She was instructed to protect the wound, gently wash and redress it twice daily, cut away dead skin, but not break the intact blisters, just let them break by themselves, and watch carefully for infection. I set an appointment for her to see me in a few days. I've had the experience of treating burns that were so severe that the nerve endings were destroyed and there was little pain. More common, however, is the unrelenting pain associated with less severe burns. And that was the case with our hot grease injury. The wound looked good, healed nicely over time, but she and I were challenged dealing with her pain until, thankfully, it gradually faded over a few weeks. The skin is the largest organ of the body, and it weighs 6 to 9 pounds. It spreads a thin but important layer over the outside of our body, protecting us from invading bacteria and viruses, managing fluid balance, controlling body temperature, and allowing for sensations that include touch, pressure, heat, cold, and especially pain. It shouldn't take a burn to realize the value of our skin. We'll be right back.
In our medical news tonight, testosterone and empathy. Testosterone is what lay people commonly think of as the male hormone. It's produced primarily in the testes and plays a role in, among other things, building muscle mass, strength, and sex drive. Women also have this hormone in their bodies, but at much lower levels than men. In women, the ovaries and adrenal glands help create testosterone. So with that as a background, researchers in the United Kingdom have studied the effect that testosterone has on empathy, one's ability to identify and share feelings with someone else. The scientists tested 16 young women, in part because women have lower testosterone levels than men. The thought was that this would be easier to identify than the effect of a boost in testosterone levels. The women each took doses of testosterone that were administered under the tongue and then took a test that graded them on empathy. The test required the female volunteers to look at photographs of facial expressions that showed mostly just the eyes and surrounding area of the face. The volunteers then had to indicate what they thought the people in the photographs were thinking or feeling. This study indicated that testosterone had a negative impact on the women's ability to judge others' emotions and that testosterone seemed to reduce empathy. Now, as with a lot of research, this was a small study, so it may not have much application to your everyday life. However, the researchers involved in this study say that one important implication might be that it could help contribute to our understanding of the impact of prenatal exposure to testosterone, and this touches upon ongoing research into the mysteries surrounding the cause of autism. Could lack of empathy in autistic children be partially due to prenatal testosterone exposure? Science is working to answer that question. And switching gears slightly, but still on the topic of autism, Temple Grandin, an outstanding scientist who has autism, recently spoke with On Call and will bring you her comments in just a few weeks. On February 24th, our show topic is Ask Anything, and we'll bring you excerpts from our interview with Dr. Grandin during that show. And we're just about out of time. Remember, On Call is rebroadcast on SDPB Digital Channel 2, Mondays at 11 a.m. Central and Wednesdays at 4 p.m. Central. Once more, I'd like to thank our guests, Dr. Richard Howard, Dr. James McGrann, and our medical editor, Dr. Rick Holm. Thanks to our phone volunteers, and thanks to you for watching and calling in. Have a great evening.
Program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
To learn more about life and health, you can order your copy of The Picture of Health, a beautiful book containing insightful essays and evocative images by On-Call medical editor Dr. Rick Holm and Dr. Judith Peterson. This book, containing healthcare advice, stories of medical history, and meditations on healing, can now be yours for $17 at the South Dakota Ag Heritage Museum. Call 1-877-227-0015 to order. This offer is made by Ag Bio Communications at South Dakota State University.